Okay, so I've handed out the review sheet for the midterm, and the midterm is going to be on the 31st of October, and it is going to be worth 150 points rather than 125 points.
Thank you.
So it says 125 points on your handout, but it's really going to be 150 points. Excuse me. And we are going to be finishing up the respiratory system this week, and then we're going to start on the digestive system. So the digestive system will be on the midterm. And then if you look at the possible essay questions, remember that I choose or probably 2 or 3 of these to be on the midterm exam, so that you have them ahead of time so that you can make sure that you understand the question and are able to formulate a response, right, that you can then recall without notes on the midterm exam. Okay. So are there any questions about that midterm exam? No? Okay. So we were talking about the respiratory system, and remember we were talking about the conducting zone. And so everything that is shown in here is the conducting zone where air is delivered to the respiratory membrane. So we're going to talk about the different components of the conducting zone and what they do from a physiological point of view. So you should be able to identify, if I was to give you this diagram on the quiz, right, which is on Wednesday, I'll give you another quiz on Wednesday, you should be able to identify the different structures in this diagram. Okay, so let's talk about the nasal cavity first. And the nasal cavity, the very first part of the nasal cavity is referred to as the vestibule. And so this is the openings right at the nostril area. So this is like if you pick your nose, this is where your finger goes. And so it's important to realize that, because in the vestibule, the tissue is actually stratified. So it's simple, stratified, squamous epithelial tissue. Oops, not simple, sorry, stratified. Boy, I have to, okay, stratified squamous epithelial tissue. Okay. So this is the same thing that lines the inside of your mouth, right? It's also the same thing that lines the inside of your esophagus. And so this is very resistant to friction and abrasion, right? And so it's not going to generally bleed. So when you get a nosebleed, it's actually in the respiratory, membrane that is inside the nasal cavity that is more easily damaged and will bleed more readily. So when we look at the vestibule, one of the things that this has, is that this has hairs. Okay, so we have hairs. And this helps to catch the debris that we breathe in. So I mentioned before that the nasal cavity is really the opening to the respiratory system and not the oral cavity. So that when we breathe, we should breathe through the nose primarily rather than the mouth, okay? So this catches debris. And we also have sweat glands here. And one of the things that these do is that these help to humidify the air. So we can lose a lot of water across the surface of our membrane because our membrane will tend to dry out. And so one of the functions of the conducting zone is to keep that air full of water so that we're not losing too much water through our respiratory system, okay? So we'll talk more about that in a minute. Okay, so then if we look at the nasal cavity, so if we look at the inside the nasal cavity, we have the olfactory membrane. And remember that the olfactory membrane is superior. It's in the superior regions. And we looked at, when we were talking about the sensory system, we looked at the sensation of smell. So when we breathe in odor molecules, and they bind to receptors that are on this olfactory membrane, and then that information gets transmitted through the skull and into the olfactory bulb. And then from the olfactory bulb, it goes to the olfactory cortex, where we're actually able to identify the smell. Okay, so that's the one part of the olfactory, of the nasal cavity. So if we look at a structure here, this is actually a cadaver. And so you can see that this right here would be your vestibule, right? And then when we look inside the nasal cavity, this is the superior region. So this is where the olfactory membrane is. And so those are the olfactory nerves and sticking down in there. And they have cells with receptors that bind to those molecules. Okay. Then if we look at the rest of this olfactory cavity, what they've done here is that they have given you a mid-sagittal section here. So remember that we have a nasal septum that separates the two sides of the nasal cavity. So the nasal septum is a type of cartilage that separates the two sides. Okay. When we look at the other tissue that is in the olfactory, or excuse me, in the nasal cavity, we can talk about the respiratory membrane. And this is pseudostratified. So remember that it is just a single layer, but it looks to be stratified. So this is pseudostratified, ciliated, columnar epithelial tissue. And so you can remember that this is what is the type of epithelial tissue in the conducting zone where there typically is not friction. Okay, so where things don't generally travel, that they can actually cause damage to the membrane. So this produces mucus. And this mucus traps particles, and then the cilia that are on this tissue actually move that mucus towards the throat. So the cilia move the mucus towards the throat. Now, there are some other structures in the nasal cavity, which are called the nasal conchae or conchae. Right? And these are protrusions. And they're believed to increase the turbulence of airflow. So if the air were to just kind of go straight through and then back into your pharynx without actually kind of moving in and interacting with the nasal passage, then more debris would get back there. And so this turbulence actually causes the air to flow in not a straight passage. And so this actually aids in filtering the air. So this helps to filter the air. Oops, filter the air. So if we were to look at this in our diagram, or actually in our image, these are the nasal conchae. And you don't need to know superior, medial, and inferior, but there's three of them, right? And so that increases, you can see how they have lots of kind of grooves and ridges in them. And that is all lined with that really fragile tissue. So if you have nosebleeds, generally this is where it comes from, right? So if your nose, if you get a nosebleed, it's not from the vestibule, but rather it's from inside the nasal cavity. Now, one of the things that you'll see here is that there is an opening in the back of the throat, and this is called the pharyngotympanic tube. So if we look at this right here, this back of the nasal cavity, back of the throat, where does that come from? Does anybody remember? Pharyngotympanic. From your ear, right? And so this is where we have the connection between the respiratory system, and then we have back of the throat, the pharynx, and the ear. And so remember that this connects to the middle ear. And that is what sometimes gets clogged when you get an infection and you get lots of mucus being produced. And then that can lead to problems with ear infections. Okay, so that's the pharyngotympanic tube back there. We also talked about the different types of tonsils. And so does anybody remember, what is the tonsil called that is up here? It's not called the tubal tonsil. We didn't call it the tubal tonsil. Anybody? What? Yes, so the pharyngeal tonsil, or sometimes that is referred to as the adenoid, right? And so that is part of the lymphatic system. And so the lymphatic system, if we catch bacteria, if we breathe in bacteria or other things that could possibly cause problems, then the adenoids are going to be able to detect that and start the immune defense response. Okay, so besides causing the inside of the nasal cavity to be humid, the air is actually also warmed. As well as filtered. Okay. Because if you think about it, when we get down into the lungs, the blood is actually in direct contact with the lining of the lungs. And so warming the air is also a really important function so that we don't have damage to that respiratory membrane and we don't lose heat across the surface of the respiratory membrane either, okay? Okay. So the next part of the conducting zone is the pharynx. And there's actually 3 parts, okay? So we have what is referred to as the nasopharynx, right? That is up right by the nasal cavity. When we get down to the mouth, this is what is called the oropharynx, right? And then we have the laryngopharynx. So you need to be able to, if I pointed on a diagram, or we looked at these actually in lab on the models, right? You need to be able to identify those different regions. So if I point to the area that is right in the back of the oral cavity, that would be the oropharynx. And we talked about how in the oropharynx we have the palatine tonsil, which are the tonsils that we normally think of, right? Now, if we look at the narrow nasopharynx, there's generally not a lot of friction here. And so that is still that simple, or excuse me, pseudostratified columnar epithelial tissue. But then when we get down here where there's actually food, so notice that the pharynx is actually a common opening to the digestive system, which would be the mouth, and the nasal cavity, which is the respiratory system. So wherever there is friction, then that would also be stratified. So I'm just going to put down that these right here would be stratified epithelial tissue. So we can say that the pharynx is the common opening to the digestive and respiratory systems. And it's important to realize that not all animals have a pharynx. So like insects, they eat with their mouth, but they actually have holes in their abdomen through which they breathe. And so their digestive system and the respiratory system are completely separate. But when we look at the fish, when they bring in water into their mouth, it goes into the pharynx and then goes out the gills. And so that's how they respire. And then that is also how they would get food, is through that common opening, the pharynx. Okay, so food here should go to the esophagus. And the esophagus is actually posterior to the trachea, okay? Air, on the other hand, needs to go into the trachea. And so if we look at the opening to the trachea, we have a structure that is called the glottis. So the glottis is the opening to the trachea. Now, food could potentially get through the glottis, except for the fact that we have an epiglottis. And so the epiglottis prevents food from entering the trachea most times. Right? It is actually a mechanical valve. And so it actually takes food in order to shut it. So this is why we chew our food and we swallow it in big bulks of pieces in what are called boluses, rather than just taking in our food and inhaling our food, right, which would not shut that mechanical valve. So if we look at the diagram, okay, this is the epiglottis, and it is actually made of hyaline cartilage. So remember, hyaline cartilage is in blue, right? And so this is a hyaline cartilage, and what it does is then it shuts down. And so as food swallows, this valve will close and will actually shut off the opening to the trachea. Okay, so that's the epiglottis and the glottis. Now, the first part of the trachea is actually devoted to language and to making sounds, and this is what is referred to as the larynx. And so we call this the voice box. Okay. And there is a hyaline cartilage that sits over the larynx that in males tends to be bigger, which means that they tend to have a deeper voice. And so you can feel that location where if you like lift your neck up here and then you take your hand down your chin, you can feel this enlargement. And that is where the larynx is located. Okay. So if we look at the larynx in a little bit of detail, it has what is referred to commonly as the Adam's apple. And this piece of cartilage is called the thyroid cartilage because it sits over the area of the thyroid gland, or around the area of the thyroid gland. And notice that it also connects to the hyoid bone. So remember that the hyoid bone is a strange bone in that it's not directly connected to any other bones. It doesn't directly articulate with bones, but here it's articulating with the cartilage of the larynx. And so inside this larynx are what are referred to as the vocal cords. So here you can see this is a fold in the membrane, and sometimes that's referred to as the false vocal cord because it's not as responsible for sounds as the true vocal cords. And so I was just going to show you a short little video that shows the movement of these vocal cords as a person makes sound. Okay, I guess if I can find it. Okay. I don't think the video's blurry.
Do that soft.
So we force air through these, and then the vibration of the vocal cords is what creates the sound. And we talked about frequency. So a higher frequency, right, would be more vibrations, and a lower frequency would be fewer vibrations given a period of time. So you can see in the low, there's fewer vibrations. At higher, there's more vibrations.
Do that higher pitch again. Do that loud. There you go.
And remember, it's the amplitude of the vibrations or the strength of the vibration that determines its loudness.
Loud.
It must be kind of hard to do that with a scope down your throat, if you can imagine. Okay, so those are the vocal cords, and they are located in the larynx, and they vibrate at different frequencies to give us sound, but we also use our oral cavity, right, and also our nasal cavity to modify those sounds so that we can speak language. So it's a combination of the movement of those vocal cords as well as like the movement of our tongue and our mouth and where we put the sound maybe up in our nasal cavity or not. Okay, so the true vocal cords are actually ligaments, hence they're white. And so you can kind of see their white color, but they're covered over by a mucous membrane. So once we get through the glottis here and through the vocal cords, we then enter the trachea. And so the trachea, right, is the structure that we can actually feel with our hands, right? And it would be anterior to the esophagus. And sometimes we have to create an artificial hole in the trachea if breathing is not possible in the oral cavity. So that would be a tracheotomy, where you actually create a hole so that you can breathe through the trachea directly. So the trachea branches into two bronchi. And this is the left and the right. So it goes to the left and the right lungs. The trachea also generally doesn't have friction in it. So it is, as we looked at in lab, it is that pseudo-stratified, ciliated epithelial tissue. And this is really important because it also produces mucus. So not only does our nasal cavity produce mucus, but so does our trachea. And this mucus serves the same function in that it captures debris that we breathe in. And during the night, for example, the trachea and the cilia are constantly moving that mucus back up to the throat. So the mucus is moved back up to the throat and then swallowed. So if the cilia are not able to do their work or too much mucus is produced, then we sometimes cough, right? So coughing aids in the movement of this mucus. And it's really important that our lungs do not fill up with mucus because then we have a hard time breathing, but also bacteria can get inside that mucus and then start to reproduce, and then you get pneumonia, right? So smoking has an interesting effect on this epithelial tissue. So smoking specifically destroys the cilia on the epithelial tissue. Now it can be replaced because this epithelial tissue is constantly undergoing mitosis and constantly reproducing itself, but it destroys the cilia for the short term. And so then what we get is smoker's cough, right? And you probably see when you read the back of a cough medicine, it says, do not take for longer than 7 days, right? Or so-and-so days. And the reason is that if you are a smoker and you don't have the cilia, you have to cough. So coughing is actually a good thing, right? Because you have to get that mucus up out of your trachea and up out of your lungs. And so if you've ever lived with a smoker, one of the things that they do is they get up in the morning and they have to hack, and they have to hack, and they have to hack, and you're like, oh my gosh, it sounds like you're coughing up a lung, right? And what they're doing is they're actually doing all the work that the cilia would normally do overnight, but it didn't happen overnight, right? So they cough in the morning. And so that's actually a good thing to get that mucus up and out of the lungs, okay? Okay, so that's the idea of the trachea as being also a place where the air is filtered, okay? Now you'll notice here that there is a difference between the right side and the left side. So it's not symmetrical. And why do you think that is the case? Why do you think the left lung only has two segments and the right has 3? Or 2 lobes?
The heart takes up a lot of space.
Right. And so the left lung, right, has only 2 lobes. And this structure right here is what is referred to as the cardiac notch. And so the heart does not sit symmetrical in the body. It sits over to one side, right? And so that's the reason for that. So the right lung has 3 lobes, the left lung has 2. Okay. So from the bronchi, we get a further and further branching. And so you can see here that they talk about primary bronchus, secondary bronchus, tertiary bronchus. You don't need to know that. You just need to know that the bronchi branch into smaller and smaller vessels until they come to what are called terminal bronchioles. So terminal bronchioles are the really small vessels, right, or air passages. So you've seen this eole before when we were talking about arterioles and venules, right? So that just means small. So bronchioles are really small, and the terminal bronchioles are connected to the alveoli, right? So they are connected to the alveoli. So this would be a terminal bronchiole right there. I go too fast? So we're still writing there? Okay. Okay, so this just shows the lining of the trachea, a cross-section through the trachea, and we looked at this in lab. So these are the hyaline cartilage rings, which provide support so that the airway never collapses, right? And then the lumen of the trachea is where the air moves. And then posterior to that would be the esophagus. And we'll look at these when we do our dissection of the fetal pig. Okay, okay, so let's talk about the respiratory membrane. And so the respiratory membrane is on the surface of the alveoli. And it is simple, squamous epithelial tissue. Right? So it is composed of a single layer of flat cells. Simple means single layer, then we have these flat cells. And this is where oxygen and carbon dioxide diffuse. They diffuse across and can be picked up by the capillaries that surround the alveoli. Now, we can talk about a formula that looks at the rate of diffusion of gases. And so this is equal to a constant, which is always given a D. And so this is just a constant. And this is a characteristic of the membrane, right? And then we times this by surface area. And then this is also times by delta P, which we'll talk about what that is in a second, divided by little d. In physics, this is called Fick's law. Fick's law. So if you take physics, you might learn about Fick's law. Okay, so SA stands for surface area. Little d stands for distance over which diffusion occurs. Okay. Now delta P is important because delta P, does anybody know what a delta means? What does that mean? Change, right? So this is the difference. So we'll say it's the change or the difference in the partial pressures of the gases. Right? So delta P is the difference in the partial pressure. So you would want that difference to be high because you notice that if you look at the rate of diffusion, if delta P is a large number, if the difference between the concentration of oxygen in the atmosphere and in the blood is at a high difference, then the rate is going to be faster, right? So it's going to diffuse more quickly if delta P is great, right? And we'll talk about that in a minute. And then obviously surface area, if you increase the surface area, then the rate of diffusion will also go faster. But notice little d is the inverse, right? So if I increase little d, what happens to the rate of diffusion? It decreases, right? And so you can tell a lot from this formula because I can tell if this increases, my rate increases. If this increases, my rate increases. If this increases, ooh, that's bad, my rate will decrease. And so we looked at emphysema in lab, and we saw that one of the characteristics of emphysema, or you might have looked at emphysema, is that the respiratory membrane gets really thick, right? And so then that is going to slow down your rate of diffusion quite dramatically, okay? Okay, so if we look at inside the alveoli itself, there are two types of cells. So they call type 1 cells are the epithelial cells. They didn't have very unique names for these. So type 2 cells, and I think it's Roman numeral, type 2 cells, right? These are what are referred to as surfactant producing cells. And these are really important because they actually break up the surface tension of water. And prevent the surface tension from collapsing the alveoli. So the respiratory membrane is moist. So this breaks up the surface tension of water. and it prevents the alveoli from collapsing. Alveoli collapse. Because water will adhere to other water molecules, and that could actually cause that really thin membrane to collapse, and then diffusion, there would be less surface area and diffusion would slow down, okay? This is a big problem, particularly in premature babies. So premature babies, oftentimes they say, oh, their lungs were not mature or weren't ready to breathe oxygen. And so they get what is called IR, infantile respiratory, IRDS, infant respiratory distress syndrome. And so their lungs were not mature and they were not producing surfactant yet. And so the alveoli are collapsed. So one way that they treat this is that they can give them synthetic surfactant. So give them synthetic. So let them breathe in some synthetic surfactant. And they can also put them on a respirator. And that forces air into the alveoli and causes them to expand. So they'll put them on a respirator, positive pressure respirator, right, which forces air into the lungs. Okay, so if we look at these alveoli, right, smaller and smaller bronchioles until they end. This is the terminal bronchiole. It ends into the alveoli. And then if we look at the alveoli in more detail, we see that there's two different types of cells. The type 1 cell is just the simple squamous epithelial tissue. The type 2 cells here are in, what color are they? Green. So the type 2 cells are green, so they're producing the surfactant. And there's one more type of cell here, and that would be the macrophages. So the macrophages are also found in the alveoli. And so if substances get as far into the respiratory system as the alveoli, there's no way to get them back out. And so the macrophages eat debris, right? And bacteria, pathogens. Right? So if you take in and you breathe in something, it gets that far, the macrophages have to feed upon it and to remove it from the alveoli. Okay. So this diagram, you should be able to identify the macrophages. So these are the large white blood cells that are just patrolling the alveoli and making sure that it is clean. And then here you can see the capillaries are really close in to the alveoli. So the capillaries surround each one of these little alveoli or alveolus, and then you get CO2 and oxygen being exchanged across that surface of that membrane. Okay. So the membrane must be moist because in order for CO2 and O2 to travel, they first have to be dissolved in water, and that's what is being diffused across the surface. Okay. Okay, so let's look at the lungs. One really important thing about the lungs is that, well, they're protected, so they're in the thoracic cavity. So they are protected by the rib cage. Once they're in the thoracic cavity, but they're also in their own membrane. And so we call this the pleural membrane or the pleural cavity. So there's actually two pleurae. So like the heart has a pericardium around it, right, with a pericardial cavity, the lungs have a pleura around them. And so the pleura that's attached to the surface of the lungs is called the visceral pleura, right? And then we have the parietal pleura. And then in between these, we have the pleural cavity. Okay, and this is filled with fluid. And the function of this fluid is that so you can breathe and there is no friction when your lungs expand and when they decompress or compress and expand and compress, there is no friction. So this prevents friction. Okay. It actually has another really important function in that it also prevents the lungs from collapsing. And this is due to what we call the pleural pressure. So we'll talk about that in a minute. The pleural pressure actually prevents the lungs from collapsing. So the pressure inside that cavity is negative and it actually causes, kind of draws the lungs and it keeps them inflated. And without that pressure, lungs will collapse. And we'll talk about what happens when air gets into that cavity and then you can have the lungs collapsing. Okay, so let's look at a diagram of the pleurae. So this is the location of the lungs. Notice that they're really well protected by the rib cage. That can also be a problem if a rib gets broken though, because it can also pierce the lung. And then we can see here that underneath it, we're going to talk about this muscle, which is the diaphragm. Okay. So looking at a cross section, this membrane that is on the surface of the lung is the parietal pleura. The membrane that is on the surface of the ribs is, excuse me, opposite. This is the visceral pleura, right? Because it's on the actual organ. And then this would be the parietal pleura. And then in between, we have the fluid, which is the pleural cavity, right? Okay. So if we look at what happens with lung pressures, we can talk about the different lung pressures that keep the lungs inflated and allow for the diffusion of gases. So we have what is called the atmospheric pressure. And at sea level, at standard sea level, the atmospheric pressure is 760 millimeters of mercury. So this is like standard. Our pressure would not be this. It would be different because we are higher up than sea level, right? And pressures change when air comes in, like we talked about, like there was a big storm, right? So low pressure came in off the coast, right? So 760 millimeters of mercury. This is the measure of pressure. That is, if it's exerted on a column of a certain amount of mercury, that's how tall that column would be, okay? So that is our atmospheric pressure. We also have what is called intrapulmonary pressure. Right? So intrapulmonary, this is inside the lung, right? So this is in like the bronchioles and the alveoli, right? So inside the lung, including bronchi or bronchioles, small, and alveoli. Intrapulmonary. Then we have the interpleural pressure, which is in the pleural cavity. Okay. Now it's really important that the interpleural pressure is negative compared to the other pressures. So if we look at a diagram that shows this, right? This is, if we have the inside of the lung is 760, like if that's standard, like the same as the atmospheric pressure, then the it is intra, not inter. The intrapleural pressure is 756, or a negative 4 millimeters of mercury. So let me go back and change that. So sorry, this is intra, sorry, intra, okay? So if this is 760, right, this would need to be 756, right? So we would say that this negative pressure keeps the lungs from collapsing. Now, sometimes we get that pressure being changed by a traumatic injury. So let's say somebody gets a knife stabbed into their lung, right? And that would allow air to move into that, cavity, and that would change this pressure. So this is what is called a pneumothorax. So this means where air enters the pleural cavity. And there's two different types of ways that this can happen. There could be a traumatic pneumothorax, right? So this is due to an injury, right? So it could be a rib that punctures the lung, or it could be something else that traumatically damages the lung. And then we can also have spontaneous pneumothorax, right? And this could be due to diseases of the lung. So it could be due to chronic obstructive pulmonary disease, right? And so you get what is called a spontaneous pneumothorax. Okay. So I'm going to show you a little video that talks about the difference between these and talks about what happens when you get air in that pleural cavity.
During normal respiration, the lungs expand and contract within the chest cavity. The lungs are encased by two layers of tissue, similar to a fist that has been pushed into a balloon. The space between the layers, called the pleural cavity, is lubricated so that the lungs can slide comfortably across the chest wall. If air enters the space, it is referred to as a pneumothorax. One type of pneumothorax, called a traumatic pneumothorax, can be caused by an injury to the chest. A blunt or penetrating chest injury can cause a small tear on the surface of the lung, allowing air to enter the pleural cavity and to become trapped. The pocket of air produces excessive pressure on the lung, causing it to collapse. A spontaneous pneumothorax occurs without injury as a result of certain lung diseases, such as asthma, emphysema, or COPD. Small air-filled sacs called blebs can form on the lungs. If the blebs rupture, they can release air into the pleural cavity. Pressure from the trapped air causes the lung to collapse. However, a spontaneous pneumothorax can also develop in a person with no obvious risk factors or disease. This condition is more common in smokers and in men between the ages of 20 and 40. A tension pneumothorax is a serious complication that can develop with any pneumothorax. If the pocket of trapped air cannot escape and continues to grow, the increased pressure in the pleural cavity can push the heart and major blood vessels to the other side of the chest. When this shift takes place, it causes a significant drop in blood pressure. This is a life-threatening condition that requires immediate medical attention.
Okay. So what do they do to treat that spontaneous pneumothorax? So what do they do?
Chest decompression.
And how they do that?
Put it in
Right.
chest so the air can escape.
Right. So you have to put the something in the chest, right? And sometimes you see this, you know, on TV shows where they'll put something in the chest and then the air will be allowed to escape. They draw the air back out. And so that creates the negative pressure so that the lung can be re-expanded, okay? So lung collapse actually has a very fancy name, and it doesn't always happen with a pneumothorax, but if the lung does collapse, it's called atelectasis. And I gotta look at my notes to spell that. Atelectasis. And this is a collapsed lung, right? And they mentioned that that can be very serious because of the pressure that it puts on the subsequent blood vessels, right? Which can decrease the ability of the blood to flow. That's the collapsed lung. Okay, so these pressures are important for maintaining the lung, but it also is the reason why we can breathe in and without forcing air into our lungs. And our method of breathing is what is referred to as negative pressure breathing. So we can talk about pulmonary pressure or ventilation, and this is a type of negative pressure breathing. And this is significant. This is versus positive pressure. Positive pressure would be like using a ventilator to force air into your lungs. Also, interestingly, negative pressure breathing is only found in organisms that have a diaphragm. And so if you look at a frog or even a reptile, they actually have to visibly force air into their lung by gulping air. So imagine that every time you had to breathe in, you actually had to use your neck muscles to force air into your lungs, and how annoying that would be, right? So we don't have to gulp air because we have a diaphragm. So only organisms that have a diaphragm are capable of negative pressure breathing. And so the idea is that this diaphragm is a muscle, skeletal muscle, that sits in a dome-shaped area underneath our lungs. And this is its relaxed state. So if we look at the lungs, and so I'm just going to draw my lungs up here, my two bronchi going into my lungs. Okay. If the diaphragm is pressing up on the lungs, the volume in the lungs is going to be low, right? So we say that this has a decreased volume, the lungs do, right? And they have an increase in the pressure, because you can think about this, if it has less of a space, then there's going to be a greater pressure in it. Right? So it's kind of like taking a balloon that's only partially deflated and like squeezing it and making it smaller, and there's more pressure in it, right? So that's a positive pressure, right? So what is going to happen is air is actually going to move out, right? Because of that increase in the pressure, air will move automatically to the outside. And so this diagram represents when you expire, right, the air, expiration, right? This is breathing out rather than inspiration, which would be breathing in. Okay. So when our diaphragm contracts, it moves down and it flattens out a little bit, right? So this would be contracted. Think of it as flattening out and moving down, right? And then what happens to our volume of our lungs is that it increases. And so we have a greater volume, right? So this would be an increased volume, And if we have increased volume, we have a decreased pressure, right? And so this decreased pressure just will automatically draw air in. And so when I think about this, it takes me a while to think about it, right? Because it's kind of confusing, because when the diaphragm contracts, we breathe in. Okay, so if you can breathe in and just think about the movement of the diaphragm. Now the problem when we think about the movement of the diaphragm is sometimes we confuse it with the movement of the rib cage, okay? So the rib cage also plays a role in breathing deeply, but it's the diaphragm that creates that negative pressure. So in your book, there's a image here that shows, so this would be inspiration. Okay, so it moves down, the diaphragm moves down, right? And then that causes us to breathe in. And then also our rib cage expands. And so the muscles that play a role in this are the external intercostals. So intercostals are muscles that run from one rib to another. And they're on the outside. There's also a set of internal intercostals. So if we go back to our diagram here, okay, and we look at the inspiration first, our external intercostals contract, and this expands the rib cage. So it contracts, it lifts and expands the rib cage. Right. So when we think about it, we think of, you know, you can feel that lifting of the rib cage. And what that does is that also increases the volume of the lungs so that there's even more negative pressure. Okay. And then on the other side, okay, this would be the intercostals, external, I'll just abbreviate that. Intercostals relax, right? And the rib cage moves down and compresses. So when you breathe really deeply, your abdominal muscles also get involved. So if you think about taking a big breath, you might actually stick out your abdominal muscles and actually allow the diaphragm to even move further down, right? And so that's going to even create more negative pressure. And then to forcefully exhale, right, we can contract the abdominal muscles, and that helps to move the diaphragm up even more, which forces air out of the lungs, okay? So the idea here is that that negative pressure just automatically draws air into the lungs, and so that's why it's called negative pressure breathing. Okay, so let's talk about gas exchange and the differences in the partial pressures. So oxygen and carbon dioxide diffuse. First, they dissolve in water. And then they diffuse from a higher to a lower concentration. Okay, so this is with their concentration gradient. So this is, for example, delta P, and then you could put O2 down here. So actually, let's get rid of the delta right now. So this is the partial pressure of oxygen. So I would say that this is the concentration of oxygen in the atmosphere or in the blood. Okay, so that means that that is my partial pressure of oxygen. The same thing goes with the partial pressure of carbon dioxide, right? So that would just be the concentration of CO2 in the atmosphere or in the blood. Okay. So the difference is what drives diffusion, the differences in the partial pressures. And so in your book, there's a diagram that shows how these partial pressures differ in different parts of the body. Okay, so we have to be able to pick up oxygen, then we have to deliver it, right? And that all needs to occur so that it doesn't take energy and it just automatically moves via diffusion. Okay, so if we look at air coming in, our atmosphere is about 20% oxygen. So if you take 20% of 760, you get about 160 millimeters of mercury. So this is what we're breathing in. And then if we look at the blood coming in to the lungs, we can see that the blood entering the lungs has a partial pressure of 40. Okay, so I'll say we could write this down: PO2 in air equals 160 millimeters of mercury. Right? The PO2 in blood entering the lungs is equal to 40 millimeters of mercury. So the difference in PO2 is equal to 160 minus 40, which would be 120 millimeters of mercury. So notice here, I'm just taking these values off of here. Notice oxygen is at a much higher concentration in the air in the lungs. And so what's going to happen is that this is going to cause diffusion to take place. So air is just going to automatically move through there, okay? Now, what about if you're not getting enough oxygen in your lungs, right? You could take in oxygen gas, right? So you could use O2 gas to increase the delta pressure of oxygen. So let's say somebody has emphysema or somebody's got chronic obstructive pulmonary disorder and they have to be on oxygen. The variable that you are changing by putting a person in oxygen is this difference in the partial pressures. And so if you change that, then you're going to increase the rate of diffusion. So this is going to increase the rate of diffusion. Okay. And so likewise, we want blood entering the tissues to be at a higher oxygen concentration than the tissues themselves, right? So here you can see blood entering the capillaries is at 100 millimeters of mercury, right? When it gets to the tissues, oxygen is at 40. And so the difference between the blood and the tissues is actually 60 millimeters of mercury, right? So the different delta PO2 in tissues, blood versus tissues is equal to 100 minus 40, which equals 60 millimeters of mercury. Okay. So that means that oxygen is going to automatically diffuse, and it will actually diffuse in tissues that are more aerobic, are using more oxygen, because oxygen will be lower in those tissues. So like if you're using your muscles, those muscles are going to be lower in oxygen, that tissue is going to be active. And so it is going to pick up more oxygen in those areas where oxygen is needed and is being used. Okay. So that's the idea of partial pressures, which are just concentration of gases and how the gases flow from a higher concentration to a lower concentration. Okay. Okay, I'm going to stop there for today, and then we'll talk more about respiration on Wednesday, and we're gonna start, maybe a little bit on digestion as well. Did everybody get a copy of the review sheet? Yeah, okay.